Hello and welcome everyone. Today's presentation is on personalized nutrition therapy in critically ill patients. Kelvin and Galileo, they have said that knowledge without quantitative facts is inadequate and only the beginning of the science. So the nutritional science in critically ill is very limited because of the inability to precisely measure patients' dietary needs and the impact of nutritional therapies, putting ICU nutritional therapy at a very early stage of scientific improvements. Now, ICU feeding is seen as a less important job than other medical therapies because of these kind of constraints. Now, ICU nutritional therapy need objective data. As vasopressors, we have objective targets like a fixed map. So for ICU nutritional therapy, we also need some kind of an objective data to analyze and to give personalized care. So we will answer the nutritional needs of the critically ill over 10 questions, starting with, when do we start nutrition? Now, this is a very important question, and the societies recommend to start early enteral feeding within 24 to 48 hours of ICU admission. The intestinal ischemia, increased permeability, bacterial translocation and dysbiosis occur within 24 hours after critical illness. Early enteral nutrition may have non-nutritional benefits by lowering these complications, infectious morbidity and ICU stay compared to delayed enteral nutrition. Some meta-analysis demonstrate that early enteral nutrition reduce mortality, whereas some have shown they do not. Early enteral nutrition during 3 days of arrival reduces ventilator time, ICU or hospital stay in COVID-19 ICU patients. In case of GI difficulties, high aspiration risk, non-resuscitated hemodynamic instability or high vasopressor dosage, enteral nutrition progression should be delayed. For patients on high vasopressors, avoid high dose eating until and unless the weaning phase of vasopressor is restarted. The Nutria 3 trial showed that low dose feeding on vasopressor extended ICU stay but did not affect death or infection complications. Now, please be aware that early high dose feeding, if done in patients before stabilization, is not associated with good outcomes. The next question, how much to feed? Now, this is again a very difficult question to answer. The objective energy expenditure measurement in ICU is increasingly feasible with advancement in indirect calorimetry technology. Now, respiratory quotient from the IC can indicate underfeeding, that is a respiratory quotient of less than 0.7, technical issues like leaks, or overfeeding with a respiratory quotient of more than 1. Now, a retrospective study linked delivering approximately 70% of the resting energy expenditure, that is IC measured, was associated with improved ICU survival. Both underfeeding and overfeeding beyond 80% of the IC targets was associated with higher mortality. Now, predictive equations often fail to accurately predict the energy expenditure in ICU patients, showing poor correlation with actual metabolic rates, especially in sick patients like the COVID-19 patients. IC guided nutritional targets are vital for ICU nutrition personalization, but the measurements should be done post resuscitation and around ICU day 3. ICU nutritional guidelines recommend starting energy expenditure at about 10 to 15 kilocalorie per kg or less than 70% of the measured IC of the resting energy expenditure, whether using enteral or parental nutrition. Now, in case of additional acute events like a new sepsis, energy delivery may need to be reduced by 10 to 15 kilocalorie per kg or less than 70% of the IC. Now, European and American guidelines advocate using IC to measure the energy expenditure. Recent meta-analysis data show no significant effect of IC-directed nutrition therapy on mortality. Now, conversely, 2 recent meta-analyses found a significantly reduced ICU mortality with IC-guided therapy. Now, new IC devices are more accurate, they are quicker, provide reading within 5 to 10 minutes, can deliver acute readings even up to 70% of the FiO2 during CRRT. Now, IC measured energy expenditure helps prevent common over or underfeeding in ICU patients, emphasizing the need for objective data in nutritional therapy. The availability of the new IC technology necessitates larger trials to define energy needs in various populations and to demonstrate the benefits of nutritional personalization through IC. Question 3. How much protein needs to be delivered? Now, muscle mass loss is significant during ICU stays, making optimal amino acid delivery crucial for maintaining the protein hemostasis and countering the catabolism. Higher protein delivery in ICU is associated with improved outcomes, reduced muscle mass loss, with guidelines recommending 1.3 to 2 grams per kg per day. However, recent studies and meta-analysis reveal that high protein intake is not always correlated with improved clinical outcomes, and excess of protein may lead to adverse effects. ICU patients exhibit diminished muscle protein synthesis compared to healthy subjects, despite normal gut protein absorption due to various factors like anabolic resistance, inflammation, and decreased muscle ATP. Early high protein intake may increase mortality risk, but higher protein intake after initial ICU days could improve survivals. Despite preserving muscle mass, higher protein intake does not always improve muscle function or the strength. Now, specific subgroups such as patients with AKI or high severity of illness may have worse outcomes with high protein dosages. Determining the optimal protein dose involves considering individual patient characteristics like the lean mass rather than the total body weight, which should be used for calculating the protein needs. Bioimpedance assessment, muscle ultrasound, and CT scans can estimate the lean mass through estimations based on population averages may not accurately reflect the individual's body composition. Biomarkers for muscle breakdown, autophagy, inflammation, and insulin resistance could help identify patients who would benefit from higher protein intake, but specific validated biomarkers are still lacking. Nitrogen balance studies reflecting the equilibrium between protein intake and losses suggest that achieving a positive balance and higher protein intake may improve outcomes. However, this approach has limitations, especially in case of renal failure or non-urea nitrogen loss. The challenge of targeting protein provision to individual ICU protein requirements remains, and the field is still developing. Bedside techniques like the bioimpedance assessment, muscle ultrasound, and new biomarkers could aid in individualization of the protein delivery. Now, the next is personalization of parenteral nutrition. How to do this? Parental nutrition is vital in ICU nutrition optimization, with trials showing varied results with the effect of both parenteral and supplementary parenteral compared to the standard or only enteral nutrition. Benefits of early SPN on late infections are demonstrated in the Heidelberg trial using IC guided personalized energy targets, highlighting the importance of preventing over and underfeeding. The decision of when or whom to start parental nutrition is a developing area in ICU care, challenging the outdated notions that parental nutrition is universally harmful. As the new Aspen guidelines and the recent large RCTs indicate, the parental nutrition when enteral nutrition is not feasible is safe and effective, with similar outcomes to enteral nutrition and no longer associated with an increased risk of infection. Now, limited evidence suggests benefit of starting enteral plus parenteral in patients of nutritional risk, though more research is needed. Early enteral nutrition of SPN, as shown in trial with major abdominal surgery, significantly reduced infectious complications compared to delayed SPN initiation. Meta-analysis on SPN indicates it is non-inferior to enteral nutrition in terms of mortality risk, length of stay, ventilator days, and may decrease the risk of nosocomial infection and ICU mortality if combined properly with enteral nutrition. Guidelines on early parenteral nutrition use recommendation as a gradual approach to energy and protein delivery, starting with an initial dose of 10 to 15 kilocalorie per kg, that is less than 70% of the IC, and protein less than 0.8 grams per kg per day, advancing over the first week. Further research is needed to understand the IC guidance. The marker of protein utilization can be used to personalize this delivery, potentially improving clinical and long-term functional outcomes. Personalization of feeding and the fasting periods. Recent evidence suggests that intermittent feeding, alternating between feeding and fasting periods, should be superior to continuous feeding. Now, intermittent feeding can activate fasting responses, promoting cellular recovery through autophagy and ketogenesis. This approach may also avoid the muscle full effect, where muscle protein synthesis only temporarily rises after the amino acid availability. Aligning feeding and fasting periods with the natural circadian rhythms could reduce disturbances in the circadian rhythm, a factor implicated in various ISO-related diseases. A pilot crossover RCT indicated that 12 hours fasting induced a metabolic fasting response in prolonged ICU patients characterized by increased circulating ketones. However, RCT comparing intermittent and continuous feeding show mixed results, with some indicating more feeding intolerance in intermittent feeding and others showing higher feeding intake and reduced aspiration risks. Now, no significant effect of intermittent feeding on muscle wasting was observed in one RCT. Current RCTs are very small and not adequately powered to assess the clinical endpoints. The fasting intervals used are 4 to 6 hours, which might be too brief to induce a significant fasting response. Future research should focus on determining the optimal timing, dosage, and the duration of fasting interval by artificially feeding in ICU patients. There is a need to develop and validate biomarkers for confirming the activation of the fasting response, the metabolic tolerance to artificial feeding, with ketones potentially serving as a useful biomarker to guide the duration of fasting intervals. Now, coming to the next question, how to personalize monitoring of the nutritional delivery. Enteral prescriptions and the delivery, there is a gap. Studies indicate a gap between prescribed and delivered enteral nutrition, with larger gaps potentially worsening outcomes. This association could be confounded by severity of illness. A sicker patient may tolerate feeds more poorly. Daily monitoring of the nutrition is crucial for clinicians, and it should align with the personalized nutritional targets. Use of computers. New systems can visualize the quantity of nutrition being delivered, significantly increasing the accuracy of nutrition delivery. Now, innovations in feeding tubes. Feeding tubes can come equipped with sensors to reduce aspiration risk during non-invasive ventilation or high-flow oxygen. Some technologies detect gastroesophageal reflux, aiding in real-time prevention of aspiration. Now, clinical trials, automated nutritional platform with an aspiration prevention feeding tube was shown potentially to reduce the ICU length of stay. Now, how should we personalize monitoring and repletion of micronutrients and the vitamins? Now, micronutrients deficiency is common in ICU but often goes undiagnosed. SPEN encourages monitoring selected micronutrients, as deficiency can lead to various complications. Now, timing of testing. Testing should begin 6 to 7 days into the ICU. Patient on continuous renal replacement can particularly be at risk due to significant losses of the micronutrients and water-soluble vitamins. The risk factors of deficiency are intestinal losses, major drains, major burns, CRRT. Inflammation complicates the interpretation of the test results. Copper, selenium, zinc, iron are critical, associated with various clinical consequences like neuromuscular weakness, pancytopenia, immune and antioxidant defense, and wound healing. Now, repletion strategy is 20% below the reference should prompt micronutrient repletion, with parental non-trace elements or vitamins or administration of repletion dosages. Monitoring results in required approximately 7 to 10 days after the repletion has been initiated. Iron deficiency anemia confirmed by hepcidin levels can be treated at the end of ICU stay with inflammation subsides. How should we personalize monitoring of catabolism and the muscle mass? Now, this is very common in ICU, that is acute muscle wasting, leading to significant functional abnormalities. The use of ultrasound can be done to monitor the catabolism. Advantage in increased ease of use, no extra cost, ability to detect muscle necrosis and fasciitis. However, it lacks standardization and has a larger coefficient of variation. CT offers more standardized and precise muscle mass measurements with a smaller coefficient of variation. Repeated CT scans of muscle mass monitoring are impractical due to cost, radiation exposure, logistic issues. However, new single slice multi-specific muscle-specific CTE protocols expose patients to less radiation. The body composition versus bioimpedance assay, historically considering unreliable in ICU due to fluid influence, but multi-frequency devices provide valuable data on cell viability, protein metabolism, and lean mass. Phase angle values and changes over time for the bioimpedance analysis are informative. Now, other biomarkers like metabolomics can be used to find out whether the muscle is being wasted. Urea to creatine ratio is a more simpler way of doing this. Need for prospective studies is required to guide the anti-catabolic therapy and understand the clinical effectiveness of markers like the urine creatinine ratio. Now, the GLIM malnutrition criteria include reduced muscle mass as an essential component of modern malnutrition diagnosis, emphasizing the need for objective measures of this particular parameter. Challenges in monitoring are, despite various methods being available, acute monitoring and muscle mass in ICU remains a challenge due to variation in the techniques, and there is an absolute need for standardization. Now, how should we personalize specialized anabolic nutrition? Now, suboptimal protein delivery is very common in ICUs. Now, unclear timing of catabolism is also a factor because it is not well understood when ICU-induced catabolism becomes responsive to feeding, prompting interest in single nutrients to stimulate muscle protein synthesis or reduce the protein breakdown. Now, the potential of nutrition in athletes. Now, leucine, an essential amino acid that initiates anabolic pathway by stimulation of mammalian target rapamycin and serves as a substrate for MPS. While its benefits are noted in elderly with sarcopenia, ICU studies remain limited. Now, the next is HMB, that is hydroxy beta methyl butyrate. It is a metabolite of leucine that stimulates the MPS and MPB, inhibits MPB. Through widely studied in athletes, recent ICU studies have shown no significant findings. The next thing that has come is the creatine. It increases the intracellular phosphocreatine and enhances ATP production, essential for MPS. It is beneficial in muscle dystrophies, but again, no specific studies exist in the ICU. The next is the research gaps that we have. Because of limited ICU specific studies, there is a lack of robust ICU specific criteria that can make for these type of agents. Now, the anabolic properties of these nutrients are suggested to be of benefit and should be investigated further. Now, effectiveness of this nutrition may depend on the duration of supplementation, which has not yet been again explored in the ICU setting. Now, to effectively personalize the use of these therapy, research is needed to understand the impact on muscle mass, the strength, and the overall recovery in critically ill patients. Finally, coming to the last question, how to personalize recovery and physiological function in post-ICU personalized nutrition, exercise, and anabolic agents. Now, patients, especially those ventilated for more than 48 hours with significant multi-organ failure, often face prolonged physical disabilities. Now, personalized approach through ICU journey is crucial for their recovery. Post-ICU rehabilitation care standards often fail to address the disabilities effectively. Now, about 95% of the ICU patients show severe testosterone deficiency early in the stay, correlating with disease severity, ventilator time, ICU length of stay, and survival. Now, benefit of testosterone or testosterone analogs combined with exercise have been demonstrated in various illnesses. Oxandrolone shows significant benefits in severe burns without major side effects. Now, persistence of the low testosterone levels that is seen in up to 96% of the patients highlights the need of multimodal interventions, including testosterone agents in non-burn or post-ICU cases. Now, nutritional delivery often worsens post-ICU. Structured nutritional strategies is required to improve outcomes once the patient is discharged from the ICU. Otherwise, after they go out, again the nutrition goes down and the quality of life doesn't improve. Now, personalized exercise programs are also important. CPET guided exercise programs are emerging as crucial interventions. Programs like REMM, HIIT utilize VO2 peak heart rate guided exercise targets for personalized intensity. Now, need for research is still there. There is an urgent need to research in multimodal interventions like testosterone agents, post ICU exercises. Utilize this technology from the elite athletic world to enhance the personalized exercise delivery to ICU survivors. So, conclusion. Now, the field is moving towards quantifying previously unmeasured aspects of ICU nutrition, like Lord Kevin's principle to measure, only then we can give the actual treatment. Innovations like modern IC devices enable precise measurement of energy needs, potentially revolutionizing the personalized nutritional care. There is an urgent requirement for trials examining these new devices and technologies to tailor the ICU nutrition. Identify markers in patients who tolerate protein and calorie, measure the substrate utilization, and critical area for research development. Now, COVID-19 pandemic has underscored the necessity of enhancing ICU survival rates, fostering meaningful recovery post-ICU, making the personalized nutrition even more crucial. Personalized nutrition should encompass the entire ICU patient population from initial admission to post-ICU recovery, ensuring that the nutritional interventions are adapted to evolving needs of each individual patient. Now, personalized ICU nutrition should be viewed as a key component of broader therapeutic strategy encompassing medical treatment, rehabilitation, and psychological supports. That's it for today. Thank you for your patience, and please subscribe to our channel if you find our videos helpful.